And as you know, ET is a chronic myeloproliferative neoplasm and can be characterized by thrombocytosis and increased risk of both thrombotic and hemorrhagic complications. The clinical presentation, driver mutation, and risk stratification tools are essential, and those will be discussed today. And we will be exploring the real-world diagnostic and therapeutic challenges for the ET. And I'm very honored to have Dr. Tefferi here. He's a professor of medicine and leading hematologist at Mayo Clinic, and he's been renowned for his expertise in MPN. And he has authored over 1,000 peer-reviewed publications and has played a major pivotal role in the shaping the work of the MPN. Thank you, Dr. Tefferi, for being with us today.
Thank you. Thank you for having me, Taha.
So this is the disclosure, and this is the main objectives of our talk today that we will be covering. And so I will start with this clinical case. This is a 58-year-old female patient with intermittent headaches, burning pain in fingers and toes, and transient visual disturbances with no history of thrombosis or bleeding. Her CBC showed isolated thrombocytosis with platelet count over 700. Hemoglobin, hematocrit, and white cell count were within the normal limits. Splenomegaly also noted on exam. Peripheral smear showed a large mature platelets. Erythropoietin level is low. Iron studies and inflammatory markers are normal. Molecular testing showed positive JAK2V617F mutation with 28% VAF. Bone marrow biopsy showed hypercellularity with increased large hyperlobulated megakaryocyte and mild reticulum fibrosis. So the first question is going to be, can we go over the diagnostic workup of ET?
So, yes, I have to say that's not the typical way patients with ET present. I think that is a characteristic way, but the most frequent way is actually they're asymptomatic. The platelet count is incidentally discovered to be increased, and erythromelalgia is quite infrequent. It is not a frequent finding. So I don't want anybody to be left with the possibility that this is how patients with ET typically present. Anyway, when you have elevated platelet count, obviously your mind rushes into the worst things first, but you have to remember that over 90% of the time, it's going to be secondary erythrocytosis associated with a number of comorbid conditions, including splenectomy. So you have to be a good internist first before you run into ordering JAK2 mutation screening and what have you. But if it is truly an unexplained, persistent thrombocytosis, then you have to consider the possibility of a myeloproliferative neoplasm, not ET, a myeloproliferative neoplasm, because any one of them can present with thrombocytosis, believe it or not, including chronic myeloid leukemia, for example, which has nothing to do with the classic JAK2 mutated myeloproliferative neoplasms. Even myelodysplastic syndrome, which is usually the typical one, is the one that is associated with ring sideroblast and SF3B1 mutation and thrombocytosis. So you have to keep this all in mind when you look at the patient. And if it is truly unexplained, I think it is reasonable to just run a quick peripheral blood mutation screening. And here you have to do all of them, all the JAK2, the CALR, and the MPN together, because you're not dealing with PV. If it was just PV, you could just do JAK2 because that's the only thing that can be found there. But here, it can be any one of those three, even though the majority will be JAK2. And if it is positive, then there's a good indication that this is a myeloproliferative neoplasm. If not, then it could still be essential thrombocythemia. So you have to keep all these things in mind. And then a bone marrow examination would be reasonable, but not necessarily mandatory. It depends how old the patient is, what you're going to do with the results, and what have you. But if you were to do a bone marrow examination, it gives you a lot of information. For example, if there is a mutation positive, one of the three that I mentioned, and you find some findings that are consistent with a myeloproliferative neoplasms, like hyperplasia of megakaryocytes, a little bit of atypia, small loose clusters, and then that speaks for ET. But if the bone marrow shows more tight clusters and the megakaryocytes are a little more atypical, they're not mature appearing, then that could be myelofibrosis in disguise. And obviously, the other possibilities outside of the JAK2 mutated myeloproliferative neoplasms, such as CML, myelodysplastic syndrome with ring sideroblastic and SF3B1 mutation, all can be easily ruled out by simply doing the mutation screening for BCR-ABL1 for the former and SF3B1 mutation for the other. Remember, the MDS with thrombocytosis could also have a JAK2 mutation, which is about 50%. So you have to keep all these things into mind, and then you make a working diagnosis. Now, I want to make a point here. A working diagnosis means a working diagnosis. You don't have to be 100% sure. In other words, you don't have to argue whether that bone marrow really looks like prefibrotic or ET. It doesn't really matter. The differences are not that much. Yeah, there is an increased risk of overt myelofibrosis, with prefibrotic myelofibrosis, but the trajectory is not as bad. So therefore, you can just make a working diagnosis, but look at the peripheral blood as well. Look at the peripheral blood. If the peripheral blood is underwhelming, all you see is a high platelet count and nothing else. There is no anemia, and you check the serum LDH, it's normal. There is no circulating nucleated red blood cells or teardrop shaped red cells. Then you say, okay, this is consistent with essential thrombocythemia, and you move ahead. Otherwise, you look for the other things.
Thank you, Dr. Tefferi. Do you want to go over this, or is I think this is very self-explanatory algorithm.
Exactly, I agree.
Do you want to just touch base on this triple negative, because sometimes reactive thrombocytosis can be misdiagnosed as triple negative versus the other way around as well?
Absolutely. Triple negative basically means any one of the three characteristic mutations, JAK2, CALR, MPL, are not detected. It doesn't mean they're not there. It means they're not detected with whatever assay you have. If you had a higher sensitivity assay, maybe you can detect them. Triple negative means that in formal, conventional assays, you were not able to pick them up. And it is reasonable to call those as triple negative. Now, the question is, are they clonal? Or could they be just like polyclonal, like reactive? There is a number of studies that have addressed this, and they are indeed clonal, at least for the most part. There might be some suggestions, some that might not be totally clonal. People have found what they call non-canonical driver mutations or other mutations that can tell you about clonality. I think here it is how the patient presents overall. In other words, we always have to think of the overall picture. We don't just depend on mutations. We have to look at, does the patient have symptoms? Is there any splenomegaly? Are there any suggestions? You also have to remember that you can have leukocytosis and triple negative. That's not normal. You could have an NGS done, and you could pick up ASXL1 mutation or an SF3B1 mutation. That's not reactive. So if the triple negative means just that, the triple negative. It doesn't mean anything else about the underlying genetic signature of that disease. And it's reasonable. I think your friend here is going to be the hematopathologist that are very good at looking at the megakaryocyte morphology and the overall architecture of the bone marrow biopsy, and let you know that whether it is consistent with a myeloproliferative neoplasm or not.
Great. I think we went over this diagnostic criteria, and anything that you want to add for post-essential thrombocythemia, myelofibrosis?
Well, that is a very, very nebulous definition. It's very difficult. Number one, you need to document a clear diagnosis of international consensus classification defined ET first. You have to have that first. You can't just say, well, you had a high platelet count for 10 years and now I found myelofibrosis, so this is post-ET. How do you know it was ET? It could have been prefibrotic myelofibrosis. It could have been myelofibrosis. So you have to have documentation that you did have an ICC defined ET first of all. Now, if you did have that, then you need a few criteria to call it. Now, it is a continuum. So some people might start having their spleen enlarged in size, and you may not find all the other criteria, including the presence of grade 2 fibrosis, but you know what's coming. On the other hand, you may have just the bone marrow that is suggestive, but nothing else is fitting. So it is not an ironclad, but you just look at the overall thing and you say, well, listen, I think we're looking at progression here, and it could be going into post-ET myelofibrosis, and that's enough. You don't have to say it is post-ET myelofibrosis or it's still ET.
Okay, got it. I think it's very important. And then I think you mentioned about the calreticulin and MPL mutations. Do you want to a little bit touch base on this clonal, other mutational profiles?
Well, nowadays, people are not content with just screening for the MPN driver mutations, i.e. JAK2 CALR. They also order NGS. Everybody orders NGS, but it's like ordering a CAT scan and you don't know what to do with the incidentoloma. You order it, but it's one thing to order it, it's another thing to interpret it. Obviously, if the NGS shows you some abnormalities, some variants, then well, probably it's clonal, as long as everything fits. The VAF is not necessarily just 50%, and it is an atypical infrequent somatic mutation or variant. But otherwise, the most important thing for NGS, in my opinion, is not necessarily that it serves as a clonal, to confirm clonality. I can confirm clonality by just looking at the patient. That's not the issue. The issue is you can find things in there that will tell you about the trajectory of the disease, the risk of leukemic transformation in the future, premature death in the future. And in this instant with ET, one mutation that appears to be reproducibly predictive of premature survival and leukemic transformation is the SF3B1 mutation. Now, in addition to the SF3B1 mutation, obviously we're finding out TP53 mutation. And usually it's the multi-hit that worries us more than just a single hit TP53. The other spliceosomal mutations like SRSF2 also need to be considered. And ASXL1 appears to be also significant, both in ET and PV. So it's mostly for prognostic purposes that you're doing the NGS.
Okay, got it. So do you want to just a little bit touch base on how they usually present in terms of the triple negative ETs, and what is the overall phenotype when it comes to triple ETs and others?
Short answer, mostly the same. However, if they are truly triple negative, that is your best type of ET to have. Let me explain. These patients have the lowest risk of thrombosis compared to both JAK2 and type 1 CALR, perhaps similar to the type 2 CALR. So the two mutational profiles you'd like to have in your patient with ET would be triple negative or type 2 CALR. these patients have a lower risk of thrombosis. Now, could they have also a lower risk of other complications like leukemic transformation? I believe so. I think triple negative probably has a lower risk of leukemic transformation. I have to prove it. I have tons of patients. I'm following them for 50 years. I will know the answer. But so far, because the number of events of leukemic transformation are small, it doesn't give me the statistical power to say, yes, triple negative is associated with a lower risk of leukemic transformation. I would like to say that in the near future.
Okay, got it. So I think I will move this side a little bit. This is a very well very well established algorithm of yours, and I always appreciate how clear it has been made. Do you want to touch base on anything here? I mean, it's very explanatory algorithm, but anything that you want to touch base on high risk or intermediate risk patients?
Yes, we just said about the very low risk disease, meaning that you don't have a JAK2 mutation, no thrombosis history, and you're young. These patients, you can actually just get away with observation alone as long as they don't have cardiovascular risk factors, especially if they're triple negative or type 2. Otherwise, one baby aspirin, enough. The low risk are still young, no thrombosis, but they have the JAK2 mutation. They are the ones who need aspirin, and probably twice a day rather than once a day. Now, the intermediate risks are your friends, like my friends who are above age 60, but they look good, they are still active, they run, they bike, they don't need to be punished with chemotherapy. These patients, if they don't have other risk factors for thrombosis, such as a JAK2 mutation, they're called intermediate risk just because they're older and they don't need cytoreductive drugs. You don't have to punish them with chemotherapy. You can just manage them with one baby aspirin a day. Now, the high risk means that you definitely have a thrombosis history, or you are older with other associated risk factors for thrombosis. And there, you're probably better off using some cytoreductive therapy. And that's that.
Okay, very clear. And then, so I think I will move to the prognosis part. Do you mind to go over different classification and overall survival prognostication systems?
Yes, I am going to advise you that all of this is going to change again soon. Okay, so if I would recommend that you completely forget about these classifications that you have listed here and just watch for a new risk classification system that's going to come out within the next 3 to 6 months. And basically, in this new classification system, we have long realized that patients with ET are wonderful. They have a median survival that exceeds 3 decades. So therefore, they act like normal people, meaning they're vulnerable to the same things that kill normal people: cardiovascular risk factors, hypertension, arterial thrombosis history, being a man as opposed to a woman, all this, being an older age. So these are what I call the host-related factors. They are more important than your little blood counts in determining how long a patient with ET is concerned. So isn't it wonderful to tell the patient that they can do something about their longevity instead of always asking for you to give them drugs? You can tell them, because these are the key determinants of longevity, is taking care of the hypertension, the diabetes, taking aspirin for your cardiovascular risk factors. These are what determine that. Now, obviously, there are other things. There are other things. And when we talk about other things, remember mutations. Mutations are underutilized in trajectory making in essential thrombocythemia. And here, I would remind you, SF3B1 ASXL1, SRSF2, and TP53. Watch out for these mutations. That doesn't mean that if you find them, you transplant the patient. It just means, hey, you talk to the patient and tell them that you're concerned, and you follow them carefully.
Okay. I know that you were giving some importance for the ALC and the WBC in your previous talks.
Yeah, those are all important. All I'm saying is, we get bogged down with specific risk models. And what I'm trying to say is get the bigger picture here. And the bigger picture, the host-related factors are important. And then on top of that, the mutations are the next most important. And the third one is, of course, the blood counts. The nice thing about the blood counts is these are simply derived from complete blood count. Absolute neutrophil count, absolute lymphocyte count, absolute monocyte count. That's it. You look at those. If all of them look good, and you're young, no thrombosis history, the host-related factors are absent, you live forever. Your expectancy is like a normal person. That's the most important thing.
Great. So I think I will move to this topic. I think is important. We have a couple more minutes left. So how do we define this hydroxyurea intolerance? How often do you use this criteria when you define the hydroxyurea intolerance rather than the patients having hard time to take it?
So this criteria are hogwash criteria, okay? They don't take into account, listen, intolerance is primarily patient, and then you, and then the insurance companies, okay? Intolerance is a very complicated concept. It is not something you can just write, if it is this, if it is that, if it is this. These are necessary for clinical trials, because in clinical trials, you have to have some criteria. But I'm not here to tell you what you use for clinical trials. I'm here to tell you how you practice, okay? So we're not gonna go into this. Basically, intolerance is, hey, if the patient is not tolerating, it's not, I don't care why, where, when. If the patient is not tolerating, either one way or the other, listen to the patient. Don't try to follow the criteria and say, well, you're still not intolerant. You just listen to the patient. The patient is having ulcers. You don't need criteria. The patient is intolerant. If the patient says, I have really bad spells whenever I take hydroxyurea or I get fever, you don't need criteria. So you talk to the patient, and the patient tells you they are intolerant. The first question you ask is, do I even need hydroxyurea? The second question you ask is, if I do need something, does it have to be a cytoreductive drug? Do I have to think about interferon, or what am I trying to treat here? I am trying to prevent thrombosis. Who is the best at preventing thrombosis? A cocktail of aspirin and Eliquis. That's it. Those are the two. You could just put the patient on 2.5 milligrams of Eliquis twice a day, along with one baby aspirin a day. You don't need any chemotherapy. So chemotherapy is not the only way to prevent thrombosis in ET. In fact, it's the worst way to prevent thrombosis in ET. But we have some established criteria and so forth, and you use hydroxyurea and you still want to use something, regulated interferon is very reasonable. Busulfan, I find very helpful in my older patients, and I still use it. So just think about this, but remember, a cocktail of Eliquis and aspirin might just do the trick. You don't have to run around high white count, low white count, and this and that.
Rapid interferon alpha 2b that was presented at ASCO for
So
SARPAS
first of all, there is nothing magical about raw peg interferon. It's just another interferon. Okay, side effects are the same. If you have Pegasus, it's as good as that. Number one, because everybody says, well, maybe it's not available, it's expensive. Look, if you have Pegasus, use Pegasus. It's the same thing. Number one. Number two, for a clinical trial, a randomized trial, to use anagrelide, which has been shown to be bad, okay, that it has been associated with an increased risk of arterial thrombosis and increased risk of fibrotic transfer. To use that, to me, is unethical, period. To use a drug that has been proven to be bad as as an arm to compare a phase 3 trial is not ethical. Okay, number one, I have a big problem with that. Number two, if you look at this study, 97% of the patients from Asia. Okay, listen, if you're going to have a clinical trial that you think is applicable to Americans, okay, you need to have representation. You need to have representation. I don't know what to do with this. I don't know what to do with this. So as far as this trial is concerned, for me, it means nothing. It really means it doesn't help me with anything. Now, well, it helps you perhaps showing that ropeg interferon works. I already know it works. I already know it works. Why would it work any different to ET than it is with PV? I already know it works. And there are many, many, many publications that show that interferon works in ET. And it's a reasonably good second-line drug after hydroxyurea. We already know that. We already know. So taking all those things into consideration, this trial really doesn't tell me anything.
Okay, awesome. I mean, I think just respect your time. I just want to conclude here. There is a couple
It's
other.
okay. You can have 5 more minutes. Go ahead.
mean, maybe this is interesting. Developing drug, the LSD1.
Oh, absolutely. No, I'll give you a few more minutes if you were asking me about these questions, because I want to put the record straight on these things.
Yeah.
This is another useless drug for ET. See, you have to remember, who are we talking about here? We're talking about patients who have a trajectory of 30 plus years. They're doing fine with aspirin and a little bit of hydroxyurea and interferon. They're doing just fine. It is impossible to show a survival advantage for a drug in ET because they live so long. We have to live 100 years to be able to show that. It is impossible. So now they realize that they're using some other measures, this goes down and that goes down and this goes down. No, key survival, key thrombosis, key leukemic transformation. Show me. Short of that, I want you to show me a cytogenetic remission. And don't talk to me about the JAK2 allele burden going down, okay? I can make it go down with busulfan. It's a matter of selection, all right? If you have a box full of mutated and non-mutated, it's just like the mutant CALR, okay? You have a box of megakaryocytes. Some have mutant, someone don't, okay? You give a monoclonal antibody against the mutant. Obviously, the size is going to go down. It's not about the size going down. The question is eradicating the clone, as with BCR-ABL1 and tyrosine kinase inhibition. So all this, you have to keep it in perspective. So either you talk on behalf of the drug companies or you talk on behalf of science. I'm not a therapeutic nihilist. I believe, especially with the anti-mutant CALR, I think it's a progress. It's noteworthy to have finally a specific drug to attack the mutation, even though it only involves maybe 20% of the patients. It is nice, but you try it and you show, okay, it lowers the platelet count. Well, I can do that with anagrelide also. That doesn't mean it's good. In other words, be truthful to the science. All right, you show, yeah, this is cool. Now, can we show that we can revert cytogenetic abnormalities, that we can completely eradicate the mutation along with resumption of normal megakaryocyte morphology? That's what you need to show. That's being true to the science. The advances are recognized, are noted, but the spins are what gives me headaches, my friend. I was looking forward to this, okay? I was very much looking forward to the results. Unfortunately, I was quite underwhelmed Okay, the results were presented, as you know, at EHA. I was quite underwhelmed. Why am I underwhelmed? Well, first of all, remember, these are good-looking patients. It requires every 2 weeks, all right, treatment, all right? And then the best they did was reduce the platelet count, okay? And then maybe lower the mutant allele burden, but not eradicate it, all right? Nothing. In other words, imagine you have a patient with ET. They're doing fine. Now you're going to subject them to every 2 weeks or every month, I don't care, infusion, all right? And all for what? What is it that you're trying to do? What is your objective? Is it to cure it? Can you really? Is there any evidence now you could cure it with this preliminary observation? I was disappointed that I did not see that. I did not see that. Now, would I see it tomorrow? Maybe. I have an open mind. I would be the first one to jump up and down if we find something good for our patients. But I'm not going to jump on the bandwagon of spin. That's what it is.
Okay, great. Thank you, Dr. Tefferi.